fact, it's my first travel to Durgapur. It's a long cherished dream. I always wanted to come and amongst friends. And I'm excited seeing the academics and the ambience. Thanks to the organizing committee, the dynamic team of BDCon 25 who have invited on such a good show, and give a big hand to the team of BDCon, felicitating them for this good shines. It's all the way greetings from Odisha, and I thought I'll be taking up this issue of type 5 because I was in Bangkok last April after the earthquake, and I saw a very good thing has happened. Entity which is almost 50-year-old and out of the classification is now reintroduced as type 5. Odisha worked in lean type 2 or malnutrition related diabetes 50 years back. We started our journey in 1970s and we had a publication in Lancet 40 years back regarding this tropical variety of diabetes, and 30 years back, Cuttack, my city, had a meeting of elite localities and the leaders of the diabetes in the world on international group on the special form of diabetics in the tropics, and there subsequently there was a change in classification with the introduction of MRTM, MMDM, PDDM, but unfortunately which was withdrawn subsequently. So this particular news that launching of type 5 diabetes working group about a class of people who have a history of chronic malnutrition, poorly developed pancreas, contributing to the insulin deficiency, hyperglycemia with a low body weight and related complications, predominantly neuropathy and infections, less in macrovascular complications, and very special phenotype was again studied with a working group. And today, next 18 minutes, I'll be telling you about this particular phenotype. This is our publication, way back in 80s in the Lancet, where the observational clinical patterns of diabetes mellitus in India was put, and predominant being the malnutrition related diabetes or diabetes with a lean body weight. And this is my publication of Professor Siddharth Das in diabetes and metabolism regarding the island B-cell response and glucose homeostasis in this group of patients. This is the monogram we brought out on behalf of Indian College of Physicians with 5 groups. One is Dr. Shamar Banerjee from Calcutta, one is Dr. Mohan from Chennai, Dr. Kanan from Madurai, Dr. Shahai from Hyderabad, and the group with Cuttack experience studied and brought out. Most of these publication and findings are based on these studies almost 30-40 years back. After that, we have a young diabetes registry at Department of Medicine at SCB Medical College, where I am the principal investigator. And in this registry, we are following up this phenotype of the patient who are lean at the same time have very uncontrolled diabetes, well controlled with the old groups, and fitting to this classical description of malnutrition related diabetes mellitus. So this is the publication of diabetes care way back in 1996, where the international group came together. You can see here those who are here, Dr. Tripathi, Professor Arjun Dash, Shyam P.P. faces the leaders of diabetes at Cuttack in the 1995, 30 years back, on a meeting on international workshop on diabetes peculiar to the tropics, where it was concluded that this particular diabetes, because internationally it was obese and non-obese subclasses, in some developing countries, non-obese patients constituting common category, and portion of them with BMI less than 18.5, they were different from classical type 1 and classical type 2, were put as the low body weight or malnutrition related diabetes. So after this meeting came the entity of MRTM, some classified to PDPM, and the MMDM, malnutrition correlated diabetes and protein deficient diabetes, which subsequently entered the classification in 1997. So I salute to my mentors, Professor Tripathi and Professor Das, who saw the entity long back, and we took so long to accept and work on this. I'm telling very quickly about the features, special features of this lean type 2 diabetes mellitus. The first is nutritional aspect, dietary intake, and response to treatment. As you know, there are distinct separate class of patients with low BMI, and they were undernourished. The habitus was lean with low BMI, and the coronary artery disease and hypertension was less, but neuropathy, infection, nephropathy, and microvascular problems were more. And almost 1/4 of the diabetic in the country belong to this class, this lean class. Let us see the clinical profile and complications. The hypertension, CAD, PPD, and all macrovascular complications were low, I have already told you. And high incidence of peripheral neuropathy and infections like tuberculosis were very pertinent because most of them were severely immunocompromised. So TB, other infections were common, microvascular complications were there, and macrovascular complications were rare. Therefore, poor middle socioeconomic status showed peripheral neuropathy, diabetic kidney disease, and infections like tuberculosis as presenting feature. The hypertension and coronary artery disease were less, and none of the subjects revealed presence of peripheral vascular disease or committed neuropathy. The carbohydrate, protein, and fat intake, you can see to this chart the pre-counseling intake was much lower in them, resulting in chronic malnutrition, and post-counseling, after the counseling, their intake has increased and their parameters have also increased. And this particular class, you can see the fasting is very high, the BMI is very low. It's average 17.4, but the fasting blood glucose of 10.1, and there were almost normal vitamin B12 and RBC folate, but the homocysteine was low in them. So most of them were controlled in the oral rocks. If you see these groups, Dr. Kanan's group, Dr. Shaman Banerjee group, Dr. Anand Nigam from Jaipur was a part, B.K. Shah from Hyderabad was a part. Most of them, almost 80%, were either on oral rocks or a combination of oral and insulin. And the inflammatory markers like HSCRP, adiponectin, nuclear factor kappa B were low, telling that it was not much associated with the inflammatory markers or classical type 2 diabetes feature. So the pathogenesis reveals the insulin resistance